Hello everyone, thank you for joining today's webinar. We will be starting the webinar in 1 minute. Hello and welcome to today's online event presented by the National Newcomer Navigation Network, which is funded by Immigration, Refugee and Citizenship Canada and is hosted by the Children's Hospital of Eastern Ontario. N4 recognizes and values the continued connections and ongoing relationships with our Indigenous peoples in Canada, the traditional stewards of this great land, which has become the home to a diverse population of other peoples. N4 is hosted at CHEO, which is housed on the traditional and unceded territory of the Algonquin Nation. And for that, we are thankful. My name is Natalie Graham, and I am the Learning Specialist for the N4 Network, and I'll be hosting today's event. I am pleased to introduce you to our speakers for today's inaugural N4 webinar entitled Newcomer Navigator, Simplifying the Healthcare Journey for Canadian Newcomers. Christine Kouri is the Manager, Health Equity and Diversity at CHEO and has over 30 years of experience in the Canadian healthcare system. She is renowned for initiatives and expertise in equitable healthcare across socio-culturally diverse and marginalized populations. She led CHEO's efforts to ensure an optimal experience for the refugees coming from Syria that were welcomed to Ottawa starting in early 2016. Suelana Taha is a Health Equity and Diversity Officer at CHEO and has a keen interest in cultural competency and advocacy for newcomers. In her role, she provides support for patients and families who require integration into the Canadian healthcare system. Suelana also provides staff support throughout the hospital and educating physicians, nurses, clerks, and other healthcare providers on facilitating adequate care through cultural competency. Today's session is being recorded and will be uploaded to our N4 website within 24 to 48 hours following today's presentation. Should there be any technical issues during today's webinar, all attendees will be informed with details on an alternate session. Before we begin today's event, I would like to take a moment to introduce you to our platform features to help enhance your participation experience. Throughout today's session, we invite you to enter your questions into the Q&A window. These questions will be answered in the question and answer session following the presentation, and we will be monitoring these questions throughout the session. You can view the questions being asked and click on the thumbs up button to upvote the question. You can also use the comment feature to make a comment or add to a question being asked. And my co-host Mariah may answer some of your questions during the session, while others will be saved for the live question and answer session. Now, without further delay, I would like to present to you Christine Kouri and Suelana Taha.
Whoops. Yes. Great. Thanks, Natalie, for that kind introduction, and welcome everybody, and good afternoon or good morning, depending on where you're joining us from across Canada. And super happy to be doing the inaugural webinar for N4, which is under my portfolio. So Suelana and I can declare we don't have any conflict of interest. We're not selling any products or anything, just hoping to share a bit of knowledge with you. Just a little bit about CHEO, as Natalie mentioned, N4 is hosted here, and I'm the Manager of Health Equity and Diversity at CHEO. So it is the pediatric hospital in our nation's capital, and there's a bit of statistics about our number of beds and outpatient visits. We have a very busy emerge. It was quiet, I must say, during COVID. We actually introduced virtual visits. I don't know that any other pediatric hospital did that, but that was a great success during COVID that we're going to continue. And now our volumes are increasing back to our usual in our emerge in the past month or so. Just interesting that we not only serve Ottawa, but we serve Eastern Ontario, Western Quebec, and we actually have the contract to provide acute care, medical and surgical services for a portion of Eastern Nunavut. So Ottawa itself is known for being quite diverse. You know, our population is now at 1.3 million for this area. It's bilingual. We have, being the nation's capital, we have a lot of embassies, so we get embassy folks as well. We are a government-assisted refugee designated city, so we do get refugees and a lot of immigrants come for economic reasons to Ottawa. So we do have a history of commitment and a commitment to diversity. In fact, our City of Ottawa actually has a guidebook for its employees on how to provide that lens to their work, and you see that image at the top there. We have Volunteer Ottawa, which has diversity and leadership training, which is aimed at providing skills for those who come from various backgrounds, especially in ethnicity, to help them develop leadership skills so they can then take on leadership roles within hospitals or other organizations. And they have been a great asset for our Board of Trustees. Goes to them when we have any director vacancies. We actually post with them, trying to augment our diversity within our leadership at CHEO as well. And you can see a picture. We had a Black Lives Matter protest this summer. Everybody, public health was very engaged in that process, and actually was there handing out masks to make sure everybody was safe, but at the same time was able to express their support for the events around the tragic murder of George Floyd. In Ottawa, we are pretty typical of the national averages. So about these stats are from 2016, but that relates to our story that we're telling you today and our learnings. That about 1 in 5 were born outside of Canada, and about 3% of the population of Ottawa are actually newcomers, meaning they've been in Canada less than 5 years. So our journey really on augmenting our focus and our understandings and what we're hoping to share with you, our learnings, began on January of 2016. So we're coming up on our 5th anniversary. I was reminded by our funder, IRCC, in November will be that commitment that Canada made to the Syrian refugee crisis, and our commitment to take 25,000 refugees within 3 months was the election promise of Justin Trudeau, and then quickly that came to fruition over a course of about 3 months between November and February. So our journey at CHEO, you know, as a hospital, we didn't know much more than what we saw in the news, and so our first real introduction was that 6 families were brought by their settlement worker and dropped off in our emergency department. So the families were not only the children with concerns, but the families. So the average family size is not the typical 1.2 kids, but rather, 3-4 children per family. One had 5 children there. And so you can imagine the volume all at once. If you're tuning in and you're from a hospital, you can imagine that creates quite a volume for our emergency department. None of the families spoke English or French. So right away we were taxed to understand, why are they here? Which child had a need? Even registrations, like, who do I register? I can't communicate. What do I do? So we do have an interpretation service at the hospital. So we called our interpreter, but meanwhile, we were fortunate in that Suelana, who's going to speak later, was actually on duty and spoke Arabic. So our stars aligned for that. So she was able to start registering the children. But even, you enter, we have Epic, the registration system. They didn't know what address they had. They're newcomers. They're staying in very temporary housing. We could clearly see they were looked traumatized, not understanding what's going on. Our physicians were very concerned. We quickly understood they're Syrian refugee. So there was a concern about, was there any type of infectious disease they might have brought because they had just arrived? There's something called MERS, similar to SARS, similar virus actually to COVID. Was that a possibility? So we put them all in one isolation room. And then, hindsight would tell you that's not a really trauma-informed approach. As Suelana actually let us know that day, they were very concerned that they were actually being sent home and they'd done something wrong, or we were going to take their children away from them. And what we saw in the children really were some very long-standing unaddressed issues. So typically, if a child is born in with developmental differences, they see somebody pretty quickly, and you get, physio, occupational therapy addressing their needs. These children looked not well nourished. Clearly, some had cerebral palsy. One was in kidney distress and actually had to be admitted. And so this was a really new lens that these children arriving at an advanced age with long-standing issues was very kind of discerning and disconcerting to our medical staff, who like, oh my gosh, we don't see this typically. We usually see earlier presentations. At that point as well, there was a lack of clarity with the Ontario government. What healthcare coverage do they have? None of them had paperwork. How do we process this? So, in emergency, we don't worry about that, fortunately, but then there were 2 of those children who were admitted, and we needed to figure out, well, how do you bill for that? And those who were able to be cleared and sent home with some follow-up, it's who's going to assist them now? How are they going to transition? Like, where do we even send them? We were calling the settlement sector, whose phone lines were either busy or their voicemail full. So eventually we figured this out, but it was quite the long stay, and Suelana did an awesome job in advocating for those families and saying what their needs were and communicating with them so they understood our intentions. And this quote on the right side is one of our Syrian refugee families. Busi had 5 children. You can see one has special needs. And what she says about her experience prior to coming to Canada was the hardest part of all of her journey. And it's on our Simplifying the Journey website that you can click on. But the most difficult always was feeling like her children were scared and she couldn't do anything about it. And so one of her reliefs in coming to the hospital, even though there was a lot of confusion at the time, was that she felt like she was hopefully entering a space of safety. So as more and more refugees arrived, so that was our initial 6, kind of woke us up. As at that time, my role was manager of patient experience, and health equity was just a piece of what I did. Now it's the whole basis of my role. All these issues that you see on the left, which probably are familiar to you, rose, and lots of staff turning to me to say, what can we do about this? We were turning to our provincial funder, which is OHIP in Ontario, saying, or the Ministry of Health, like, who can help us out? This is very overwhelming. They were saying, well, this is a federal decision to take these, so call the federal government. We'd call the federal government. They'd say, well, healthcare is provincial, go to the provincial. Anyway, so we did this roundabout, and meanwhile, we're stuck in this kind of system of a lot of people working long hours just to help these families. Our social workers were trying to quickly educate themselves on what's going on, how can we assist, and quickly we were very overwhelmed. So what fortunately happened after enough calls to our Ministry of Health is they said, look, just run a tab for 6 months, figure out what you need to do. We're in conversations with the federal government and we'll figure it out in 6 months, but just do what you need to do. So I reached out to my counterparts in pediatric healthcare hospitals across Canada, and I was saying, what are you doing about the Syrian refugees? And the response inevitably at that point in early days of 2016 was, what Syrian refugees? We're not seeing any. And so we came to know later that Ottawa was chosen as one of the first cities to see these acutely ill children, but we just didn't have the luxury of a heads up. So in reaching around and figuring out, well, what can I do? What kind of role can I have? We clearly need help. We came up with this idea, and frankly, Suelana and I brainstormed, and our manager of spiritual support as well was doing a lot of support, and we came up with the idea for a Syrian refugee navigator role. And really what I did was I morphed the Indigenous navigator role description that I reached out and Googled, as well as I knew about a breast cancer navigator role that really helped facilitate that. So that's where this idea came from. And so I'm going to turn it over to Suelana, because we developed her job description together, and she fulfilled it, and she's going to speak about her experiences actually as a navigator.
Good morning, good afternoon. Thank you for having me. So as it states on our slides, it was in our first year. We had no idea what we were going to expect. We could have expected children who were 100% completely healthy. We could have expected families who are coming from higher education. We could have expected families who are farmers, or we could have expected families with no education. In the beginning of our influx of Syrian refugees, we started to receive families who were from communities that focused on farming, families who had little to no education, families who the parents were married very young and didn't have the opportunity to go to school and were working immediately. So between 2015 and 2016, we saw 2,500 Syrian refugees. 60% were under the age of 15, and most families were 5 to 8 people in size. And that's very common in the Syrian culture, and we're still seeing it till now, families coming in with at least 6 children and having several more while they're here in Ottawa. Especially when it came to communication, we found that we lacked the opportunity to properly communicate with our families, since 95% of them spoke no English or French. And when we tried with the English, we had no success. We tried with the French, and that too was unsuccessful. At the same time, we had children with very visible health needs. A lot of the families were not even aware that their children had severe medical needs, and they had found a way to adapt with those needs in refugee camps and in their homes back in Syria. So within our first year, in 2016, we welcomed 236 Syrian refugees. Those 236 Syrian refugees, there was 765 outpatient appointments. So we have one family who had at least seen our outpatient clinics at least 15 times within 2 weeks. Within the 236, there were 250 emergency department visits, since we didn't have family doctors at the time who were accepting Syrian refugees. And within those visits, 60 admissions happened. And it's not 60 individual patients. Some patients were discharged and they were returned back the next following days, because families had a hard time understanding their discharge instructions without any proper interpretation services to provide to them, making sure that they understand their needs when they were home. Then the referral resources to CHEO. So realize that once our families leave CHEO, where are they going? Where are their other secondary resources? So there was Reception House that's staffed by the Catholic Center of Immigrants. We have the settlement workers who work at CCI, Jewish Family Services, Somerset West. We have clinics in the community. And then we have the self-referral from the emergency department. And then we're gonna skip to the next slide. So we talked about the navigation key functions. So we do have our Syrian refugee families, but there are other functions associated to supporting our families. We have the community, and the community isn't just Ottawa residences. These are other Middle Eastern communities in the city who are very open to supporting our newcomers, supporting with food, supporting with shopping, supporting with furniture, supporting with finding work, and just being a friend and a supporter. Then you had the hospital, such as CHEO, supporting our newcomers at the same time. And then we had the patients who were supporting each other. So we had families who were admitted, and just 3 doors down in the unit, there was another family. So they're able to help and communicate with each other and support each other based on their experience at the hospital. And then when this all works together, then you have your levels of issues. So then we would centralize e-referral intakes with lead physicians to match clinical issues to the right services. So we can have children who were seen by neurology, but then at the same time, they're going to be seen at OCTC, within that support with physio. We would ensure that families engaged within their transportation and their interpretation services. So we would have families saying, okay, I need to go here, but how do I get there? So families were taught how to take a bus. We were teaching families how to provide transportation within their community. So a friend of the other friend would arrive and help and take them to appointments. And that's how they communicate with each other. We also noticed that families weren't engaged as much when they didn't have interpretation services. Now imagine yourself, you go on a family vacation, you decide to go to Japan, and you fall and you've broken your ankle. I would have no idea what to do in Japan and how the healthcare system works there. And I'm sure many of you wouldn't either. Now, imagine not having an interpreter, not knowing how the healthcare system works, not knowing how much you have to pay and how it works here. You go to triage, you see the nurse, you wait in line, you wait in the waiting room, you have your x-rays done, a diagnosis done based on your x-ray, and then your treatment plan happens. But I'm not sure how that happens in Japan. So interpretation services was a key factor in helping us communicate with the families and let them know how things were going to merge together. One-stop call or page for staff concerns about patient families who are coping or who needed support. So there was myself and our spiritual support manager, Geraldo, who was helping staff and families understanding the needs for each other. It was one-stop phone or page for families with concerns. So we had families who would call my office and say, you know, I have a concern. I don't understand a dialect of a certain interpreter. I'm just wondering if you can make a note on my patient's chart. Just if we could not have this interpreter again, not because they weren't good at their job, it's because the dialect just didn't match. We wanted to make sure that our families understood 100%. There could be other concerns such as, I've gone to my appointment, I've left my appointment, and I still have no idea what's happening with my child. So our staff, innocent enough, would just do a consult, see the patient and move forward. But they didn't realize that the equipment they're talking about, the G-tube and x-ray, families are not familiarized with that. We have families we've had children who were set up for life support machines. When the families see the waves on the monitor, they think that's their child on their own, pumping their blood on their own, when in fact it's the machine doing that for them. So we have had families have experiences thinking it was a misunderstanding. 10 to 16 patient referral per day. We've had a lot of referrals in the beginning of the time. Patients would be seen by a emerge doctor, and there was, for each patient, for each family member in the room, so you'd have 4 siblings in one emerge room, each patient would have at least 4 to 5 referrals. One referral to neurology, one referral to see and to have an ultrasound, one referral for physiotherapy, one referral for orthopedics. It just accumulated. So we'll go to the next slide. So then we had the hospital level issues. So we needed to recruit more interpreters. We had at least 6. 6 was not enough. We currently have about 16 right now, just Arabic interpreters. Interpreters were required at all times, 24/7. I even found myself coming to the emergency department at 3 o'clock in the morning, providing interpretation support because we couldn't have interpreters come in on time. We had cultural competencies training for staff. So we had staff innocently, why are families coming? Why are Syrian refugees coming to Canada? Of all places, why are they coming to Ottawa? I don't understand. When we did presentations, we showed the before and after Syria. It really made staff understand why our families are coming here. And there were times we had staff members cry because they didn't realize the severity of the war that was happening in Syria. We would show them a nice cafe, everyone sitting around having a good time, drinking coffee, and then we'd show them it's completely obliterated, it's nothing left. We would show them the children's hospital that was highly equipped with state-of-the-art equipment, completely destroyed. We would show scenes of hospitals being destroyed when they knew there were patients in there. So it really affected our staff, and we found the attitude and the tone of our staff changed. Then the key resources we developed in Arabic. So we have our emergency department parent pamphlets, and those were translated in English and French, since our hospital is a bilingual institution. We've provided Arabic translation to 95% of those pamphlets due to the fact that most of our families didn't speak English or Arabic, nor did they, English or French, nor did they read English or French. Providing these pamphlets, we've noticed that families wouldn't return to Emerge for questions. They were discharged and understood the care that their child needed after being discharged from Emerge. So then we advocated for support, increased funding for taxi chits, food, support while being admitted, support while being at the emergency department, and support for clothes. So we asked for an increase for social work because social workers at CHEO are key supporters for our refugees. They're there to help us provide with funding, with all the necessary needs that we need to support our families inside the hospital and outside the hospital. So on our CHEOnet website, we have an internal site called CHEOnet, and basically staff who need support when it comes to health equity and diversity needs, my contact information is there to provide support for staff whenever they require it. I have times where I have staff call and say, you know, I've had this scenario with this father. I quite don't understand why mom never answers the questions when she's the primary caregiver, but dad answers them there. And you have to provide that cultural understanding that the father believes and he acts as if he is the primary, he's the neck of the family, but we all know the moms are the neck of the family. But we have to play that role, right? So we try to educate the staff about what they're thinking culturally and how the staff can approach it. If the staff is still finding times that they're having difficulty connecting with the father or the parent, then I try to intervene and join at the next appointment and try to give my insight, how it is important to having both parents being involved in the patient care plan rather than just one parent. So then we created these algorithms. Staff are like, well, I'm not sure when I'm supposed to call you, or how do I call an interpreter, or when I'm supposed to call an interpreter. Do I call an interpreter triage? Do I call an interpreter when the patient's in the room? When do you come in? Last minute, at the beginning? So we created an algorithm, basically a step-by-step. When a refugee arrives to the emergency department, we need to identify them if they're a refugee, a landed immigrant, or new to the country. We can have diplomats come in, and we did not provide support for diplomats since they were provided support from their own diplomatic institution. Landed immigrants did receive support, but they weren't classified as refugees because the landed immigrants were classified as a group who were supported to be here. So I can support an uncle to come in as he is a landed immigrant ready to come to work. And then the algorithm would requires interpretation services. Then you would provide and continue to the next algorithm, which would be for interpreters. It's basically to help staff just to go by step. And we've noticed that if you skip a step, you're actually causing a lot more barriers for the families to move forward. Especially when it came to the interpreters, the triage nurse needs to identify a language barrier. If you don't identify the language barrier at triage, how are you supposed to know why the patient is there? When you know why the patient's there, you can properly provide acuity for the patient. Either they have to go into our ambulatory zone side, which is like I like to call little urgent care, or the main side where you have a high acuity, you need to be seen by a doctor fairly quicker. But then we realized while I was working in Emerge that sometimes we just couldn't get an interpreter on time, or just sometimes we couldn't even get an interpreter. So I took a body diagram and I had it translated in Arabic so we can at least be able to have the family point out where their child is having any pain, discomfort, or where their concerns are coming from. On the next slide, we also created a pain scale. So when we're talking to, for example, a shy 14-year-old girl who is really having a hard time communicating with us and who is not saying much, we wanted to know how much pain this child was in. We wanted to provide them with Advil or Tylenol. We wanted to provide them comfort. So with this pain scale, it was able to help us communicate with families and the patient to understand what needs they required while they waited to see a doctor. So we had some serious community issues. Absolutely had issues inside of our hospital, like we like to call inside our little home. But once our families left our care, what was happening to them there? We needed to make sure that they had a settlement worker, so someone who can work with them in the community. Since my role really focused on inside the hospital, we wanted to ensure that there was multicultural healthcare workers at community clinics where there was multicultural understanding, diversity, comprehension. And then there were issues at school, sending kids to school without lunches, sending kids to school without jackets, understanding when it was time to pick up the children, not to let kids come to school sick. Those are new things for families that they had to learn as well. The primary care, since For the beginning part of the Syrian refugee arrival to Canada, the first 2 years, physicians were accepting IFH. It's the interim federal health card. So basically, it's like a health card for newcomers. And at the beginning, physicians were very helpful providing that care. But what it didn't do was provide the full payment as of a OHIP would do. So now at this time, we're having a hard time finding primary care physicians who will still accept OHIP. Who would still accept IFH. Then there was palliative care hospice, which was very difficult to talk about to our newcomer families from Syria who were primary Muslim and who had a hard time understanding the culture around palliative care here at CHEO. A lot of families were told that when you come to Canada, you're going to be receiving the best care, 100%, and we're going to fix all the problems your child has. So we would have families who would come in with children with cerebral palsy, and they would say, okay, you're going to be able to fix my child's going to be able to walk, they're going to be able to run around and get married. And then we are the people who look like the bad guys have to say, no, actually, that's not it. But our job is to make sure that your child is comfortable and they can make the best out of their life. Then we had issues with equipment suppliers. So the demand was so high that the suppliers were having a hard time bringing equipment on time, especially like feeding pumps, G-tube equipment, and extra equipment for care at home. Since IFH didn't cover all that, we had to advocate for IFH to cover equipment, since a lot of families had to wait for their OHIP, which would take up to 2 or more years. So some families were delayed in receiving their medical supplies at home. Adult hospitals was a completely different culture. I myself currently as well work in an adult care hospital while working at CHEO, and I still, walking through the hall, still see refugees who seem to be confused and lost where they're going. I feel like there was a lack of the work that we've done at CHEO to provide our newcomers in the adult care what kind of support is out there for them. Community leaders helped us tremendously. They helped us advocate the need for funding. They helped us advocate the need for staff and support between the hospitals and the community leaders. When we worked together, we found that we were able to cover all the little holes in the gaps and understand how the system worked all as in one identity. The food banks were going dry very fast. Our families were reaching out to food banks almost every day, and the food banks were reaching out for support. And this was highly because of the newcomers who were arriving between 2015 and 2016. We had some serious privacy issues with private sponsors. Now, we understand private sponsors came and helped families out of the goodness of their hearts, and we still highly appreciate their work. The issues that we found was that private sponsors believed that they owned the families, that they were their legal guardians, that they were their legal advocates, and that they could make the decision based on the child's care and needs. But actually, that's all incorrect. The private sponsor is basically a group of people who are supposed to take you by the hand and support you and guide you. But they're not the person who is supposed to make the legal decisions for the patient. And at times, we would have to escort private sponsors out of the clinical room because families were so embarrassed and shy to say that this person who has helped me come to this country safely, I am unable to tell them to let me make the decisions on my child's care. A lot of families had a hard time saying this, and a lot of families refused to say it, but you can see it on their faces that they were uncomfortable. So there were times where we had to provide education to private sponsors about HIPAA and how the legal obligation of CHEO is to allow families make the legal decision for their own child. Our chief privacy officer was very helpful, Christine at the time, was able to help us and educate staff again about privacy. I find that no matter as much as you educate people about privacy, we always trip sometimes, because sometimes we just want the best for others, but there's still a legal obligation that we have to follow. So we'll move to the next slide. So
Suelana asked me to do this slide because she's too modest to say our evaluation metrics of her role. So I will cover the slide and hand it back. So I knew that we had 6 months of funding, and somebody was going to ask me, and we'd have to make a decision. Do we go forward with our Syrian refugee role or not? I have to say, even within 6 months, you can probably tell Suelana's passionate about this. And she actually said, you know, I can do more than Syrian refugees. I can do all the all the newcomers. So what we proposed is we would morph the role to a newcomer navigator at that point. So in terms of metrics to evaluate, we really looked at the profile of those families that Suelana outlined, the 256 families from the first year, and compared it to our CHEO average. So we use a system called EPIC, and so we were able to pull some data and just compare. Definitely the Syrian refugees, as you can imagine from Suelana's description of the families she saw, were much higher in acuity. That was validated by our reviews that on average CHEO families would see 1 subspecialist on average, but these families on average saw 3 subspecialists. So there definitely was a range. Some had maybe simple things, and some, as Suelana said, had like 15. They needed OT, PT, neuro, etc. But the average was 3. So we knew they were triple in one measure. That was one measure for us to look at their acuity of their needs from a hospital perspective. Of those children, we did have 5 pass away during that first year there, and that was devastating for those families. And part of their motivation of coming to Canada when they were offered was, I am coming, and a lot of parents said that, I'm coming here for my children. I'm coming here for their hope, for their future. And so when their child would pass away, that was we felt like we were adding devastation on top of previous devastation. There was also a recent study that came out, a book that was published about their experience, and they showed that, our rush to help these families, best of intentions from Canada, but our commitment was once a Syrian refugee was identified, they would be out of those camps within 36 hours. So if you imagine you've already been displaced, if you put yourself in their shoes and you have your children, you're not sure, and somebody comes to you, do you want to go to Canada? You're like, where is that, right? Suelana has described, a lot of them did not have a lot of education, would not have known where Canada is or details about our country, but for the hope of their children, they'd say yes, and within 36 hours in that camp, they don't have much time to say goodbye. The other families they bonded with, they could have been in that camp for 5-6 years. It may be the only environment the children knew. They don't have memory of their home in Syria. And so what we witnessed was also that additional trauma of Canada on best of intentions, but really this quick, and here you are in Canada, that was an additional trauma actually to their experience, which is something that's now clinically been studied and published. So when we looked at their healthcare usage, when we don't have refugees so we had to judge them again against the CHEO average. We anticipated that they would have a much longer length of stay because of interpretation needs, of resources, but actually with the implementation of Suelana's role, we were able to stay pretty much on track. Their average length of stay was only 1 extra day versus the CHEO average, which I think is around 6 days, and theirs was 7. Their emergency visits rate was actually about the same as our average CHEO population, which was great. Considered the acuity of what they had, you would anticipate a lot more visits, but as Suelana would interact, they could call her, they even had her page. She was very gracious and was offering to be paged 24/7 during that initial crisis. And they would just say, I don't know why I'm supposed to come, like, who do I talk to? I'm worried about this or that. And she could provide that liaison to the staff, so they wouldn't come to our emergency department. They could instead talk it out over the phone with the use of an interpreter with their clinicians. So it was great for them to be able to just reach out and ask somebody in their own language and ask their questions rather than come to our emerge. Now we do see some inappropriate emerge visits, as we do with other Canadians. An interesting aspect, your average Canadian might just say, well, I just want to go to emerge, it's convenient. There's a nickname in pediatric care about the Starbucks moms that come with their Starbucks and their child's got a sniffle, right? And they're not there appropriately. The inappropriate use we found among the refugees was actually that I can't get somebody to speak Arabic to me in the community. I know I'll get an interpreter, I'll be able to understand, and that lovely Suelana's there, so I'm just going to go to CHEO's emerge. So we did see some inappropriate visits, but not more than the Canadian rate. Their no-show rates, at CHEO, it's, I don't know why they're so high, but 15% is the average for no-show rates across Canada pediatric hospitals, and there was about the same. So we were able to show it wasn't higher. We expected if you don't understand why you're going to do an appointment, that you would no-show. One of the things that we were able to correct that we caught early was, so a lot of these children had to have surgeries, and the fasting instructions, our instructions we discovered weren't great. So as a Canadian, we say it's okay to eat Jello. If I'm new and I see the word Jello and then I go to the store, there's Jello pudding. So we would have all these children come in who had eaten any Jello product at all because we said Jello is fine, thinking as a Canadian we mean the jiggly dessert. So it pointed out some of our other issues that we had where maybe were not always clear to folks. We did do surveys. We did experience surveys. We called every one of these families. We used an interpreter that was new to us, that hadn't serviced these families. And as well, I had another staff, Sahar, who spoke Arabic and could call them. And so what was meant as this quick phone surveys ended up sometimes these hour-long dialogues, because these families were so thankful to talk to somebody and speak to their experience. So while we were asking them about their CHEO experience, they wanted to explain, well, here's how I came to come to Canada, and here's been my whole experience of coming to Canada, and here's what I hope for the future. So these surveys took a lot longer than your typical surveys you might do over the phone, but that was great data we got about that from our qualitative basis. They rated, so we have a standardized questionnaire we use at CHEO from NRC Picker, and so we chose 10 basic questions to answer and compare, and they actually rated us as higher in terms of quality of care questions. In terms of, one of the questions was around cultural, like did we adapt to their culture, and their ratings were actually above average for the CHEO, which was great. We asked about the interpreters. We were, as Suelana said, we were hiring new interpreters as quickly as we could. So because we were facing, at first, our 6 interpreters were here day and night. Sometimes they would go home to sleep and come back just to help us out of the goodness of their hearts. So I was a little bit nervous about the quickness we were engaging these interpreters. So we wanted to make sure that was a positive experience, and they did rate them as very well. And if there were issues, as Suelana said, around dialect, we were able to correct that. So they were happy with that. And then we asked about Suelana. How was your service with her? Was she helpful or not? A lot of times what we realized is Suelana had done all this behind the scenes work. She'd done education, staff were reaching out, how do I do an interpreter, etc. So she was actually involved in their care, but behind the scenes, and promoting that relationship between the staff, as you would want with any other staff, any other family. You want them to have a direct relationship and not an intermediary. So a lot of them actually didn't even realize she was there behind the scenes, smoothing their path and their journey at CHEO. But those who did interact with her were always phenomenally positive about how helpful she was. So that's what we went forward with to CHEO and suggested we continue. And so we were able to get, we got a little bit of funding from the Ministry of Health again, but CHEO absorbed the rest, and we did an additional 2 years, and now it's a permanent position that we'll talk about soon. So I'll hand it back to you, Suelana, about your life in 2017 and beyond. You're on mute, Suelana, sorry.
Sorry about that. So as it started in the beginning, like Christine said, it was first seeing refugees, and then we wanted to expand more. I wanted to provide more services. I was being reached out almost every other day about, well, we have these newcomers from Burundi, we have these newcomers from Somalia, why can't you take these newcomers? And it's true, why couldn't I? So then it became Newcomer Navigator, where we captured everybody. And then we wanted to make that even bigger. I want to take on more because I like being paged 24/7, right? So we created the Health Equity Coordinator, supporting Indigenous youth, vulnerable youth, newcomers, and the occasion landed immigrants who still need some help navigating the healthcare system. But while the Health Equity Coordinator, such as myself, is running right now, what we've noticed is that our interpretation service is so great that we have clinics and services that are somehow connected to CHEO in the community and want to use our interpreters. However, we cannot provide our interpreters to outside of CHEO since the budget would be coming from our cost center. So then we provide education to how can your organization start an interpretation services program? And then I try to help them create that little structure so they can move on their own. So that's how we know that our interpretation service is working, because physicians are in their community, have heard of us, have worked with our interpreters, have really enjoyed how the service is communicating with their families. While working as a newcomer navigator, I had a little girl ask me one day, since I love Halloween more than any holiday, even my own birthday. And she said to me, she goes, how do you celebrate body parts all over somebody's lawn when I've seen them in the war? And I just like stood there looking at this little girl, and I'm like, how do you even comprehend that? So that's the additional trauma that I've learned about our newcomers while becoming a newcomer navigator. The additional trauma as well is the isolation rooms that we have in our hospital. So when you tell a family that you can't leave the isolation room, it's like telling them all over again that you're barricaded in the spot and you can't leave. And it's not safe for others. So in each box, I've learned something extremely different and new history about the trauma that our families have experienced here and how it's affecting them here when we see it as something completely innocent. So we see Halloween as a time for passing out candy for children, but our newcomers, those kids see it as, why are we celebrating the dead and body parts and all these little things celebrating for candy? So it gives you a different perspective on things. At this time now, I think all these roles are now one, but they all support the same thing. And who knows what's going to happen to it in the next few months. Maybe we'll support the Mars mission that the Tesla guy wants to support and go from there, and we'll take aliens. That's going to be our new portfolio. So at this point, I think this one's going back to Christine.
Yeah, thanks. So I see we're at 1:45 and I want to allow time for questions. So I'll just summarize where our approach is now in case that's useful to expand your approach. We know of one newcomer navigation role, which is at the Montreal Children's. Otherwise, we have not seen that in other pediatric hospitals. It tends to be a lot of social work involved, or there's just starting to be these health equity lens. I find, especially as of this year, with again the attention to Black Lives Matter, and as the rising of our awareness around Indigenous issues, I'm finding more and more hospitals are paying attention. It's usually still morphed into a separate role, but just in case it's helpful to you and how to frame this at your organization, who maybe can't dedicate a whole role, but these are things that for sure a hospital should be approaching, and I do feel that our lens is changing towards hospitals being more aware of these issues. So for ourselves, we look to Health Quality Ontario, who has some resources online. If you Google that, they have actually a toolkit for health equity. We use their definition of all the definitions out there for our approach to this, and that's just really no matter who you are or where you come from, they'll get the same access to their full health potential. We use this as our model towards that. So you may have seen this in other presentations or online about equality. So not treating everybody the same isn't helpful. Not everybody, for instance, needs an interpreter. So an equitable approach is giving people the supports they need. You don't have accessibility issues with people that don't have that aren't disabled. So again, an equity example would be providing those interpreters, providing access to trauma-informed care. A justice would be more around having providers that actually speak the language. So then the source of the inequity is removed. Of course, that's always challenging, and there's lots of system level issues that can prevent that. For staff, it would be recruitment, for instance, but there's certainly things we can do to help with the justice approach. If you have education of your staff, we did have, I would say, our interpreters. So we would hear reports from our interpreters about staff making inappropriate comments, assumptions about our refugees. We know that a lot of them came with just the clothes on their back or very few things. So what do you choose if you're a man and you're hoping to be employed? You'll bring your suit. So we had a lot of fathers wearing suits that were Syrian refugees, and then we'd have staff going, they can't be that well off, they wear a suit. And our interpreters would report this back, and then we would do some targeted education that way. So if people understand, if that's your only thing you're going to bring something you think you might get an interview in, that's your only suit, and he's probably washed it 100 times. And also there's a respect of people, when you see somebody you view as authority, that you would dress up for that occasion. So you would see them dressing their children in their best clothing when they would come for appointments, versus your average Canadian kid is sometimes coming in their pajamas or pajama pants if they're teens. That's not our culture. So some of that education really promoted that understanding, which is more of a justice if you understand and you know how to approach that. Just in case people think, oh, okay, the Syrian refugees have come and now there's less, and so can we get back? I've had this question from hospitals. Well, we're going back to our life as normal, right? Our plan for Canada is that we're going to be increasing the number of immigrants every year. In the year of the Syrian refugees, there was 290,000, so a lot of economic immigrants come, as well as refugees. So you see over time, the plan is only to increase this because we really don't we're not replacing ourselves as Canadians. So if we want people to do the roles as our baby boomers especially retire, we need more and more folks. So that is the continued plan. It was impacted by COVID, but they're actually doing catch up right now in settlement, in bringing more newcomers right now as the settlement sector has reopened as well. So they're getting strained by the system a bit. This is a framework as well that might be helpful to you from the Institute for Healthcare Improvement around health equity. This is the way we frame our work. There's 5 different streams we look at. The one I wanted to highlight is that bottom one that I think we forget. We really focus internally as hospitals or as organizations. We make it a priority. We'll maybe put resources. We try and figure out who needs what populations are really relevant for us that may not have an equitable approach. But we often skip the last step, which I found extremely useful for our success at CHEO, is developing partnerships with our community organizations. So I sit on the local immigration partnership table at their health and wellness table. I am the only hospital that's represented, and yet we know, if you look at those stats again, 1 in 5, or now they're saying our more accurate stats now is 1 in 4 have been born outside of Canada that are in your catchment area if you're average Canadian. So we need to know about this. We need to link with them, and we need to work in cooperation rather than working in our silos and just expecting families to, just kind of transition and not have supports or don't understand. We need to understand each other's realities if we want to make the best care plan possible. As Suelana said, our focus of our work for health equity is newcomers and Indigenous, and the overlap being those vulnerable children and youth, as well as LGBTQ, children in care of the Children's Aid Society, and our racialized children. That's really what we've chosen as our focus for our work for the next 2 years. Finally, I just wanted to touch on impact of newcomers and health. Public Health Ontario seems to be the only province that has accumulated statistics and just now released it related to COVID. So again, newcomers represent about 25% of the population. In Ontario, they're about 45% of the COVID positive cases. And the reasons why are listed on the right. So you see that us other Canadians, we have a lower rate. We're 55% of the cases of COVID. So we know their housing, if anybody's dealt with newcomers, the housing sometimes, Suelana did great advocacy. Sometimes the housing was really disgusting that we put them in. It was embarrassing, I felt, as a Canadian. The newcomers never complained, but I felt horrified by some of the cockroaches and mold that they were put into. And so we would do advocacy, but they're big families. And if you're in an apartment building with a lot of other families, they tend to play. The children play in the hallways, and so you find more cases. A lot of the newcomers quickly get those frontline jobs in restaurants, in the healthcare aid type roles. There's a lot of new Canadians that work in the long-term care home. So I know our 5 deaths that we had in Ottawa were all people that were immigrants that died, that were staff in long-term care homes. And again, understanding if you don't speak the language or you don't know where to access public health info, you may get it off Twitter, right? We'll see stuff on Twitter. If you're a new Canadian, you're not reading Twitter, you're not getting stuff off Facebook, you're not probably, if you watch the news, you may or may not understand. So there's real reliance on the settlement sector to explain to them, and yet settlement workers can have 50 to 100 families under their portfolio. So expecting them to do our public health is not great. Our Public Health Ontario started translating all our things into Arabic and hoping that families within themselves will share amongst themselves. And access to primary care remains a concern, even above IFH. A lot of times they were giving OHIP for the GAR, the government-assisted refugees, get OHIP now in Ontario right away. There's no 3-month wait, but still we see it, and we've seen this across Canada, where the primary physicians are like, it takes more time. I don't know how to get an interpreter. And in Ontario, if I'm a primary physician and the interpreter, I have to pay for it myself as a practitioner. So that creates a barrier. So then again, not having primary care makes you more susceptible to COVID, we know. So that ends our presentation. I'm going to open it up, hand it back, I guess, to Natalie, who's going to, I saw some questions popping up. So I don't know if they were for us, and so happy to answer any questions you have. Use the Q&A, I guess, Natalie?
Yes, thank you, Suelana, Christine. That was a very informative presentation. And we do have a couple minutes left for some questions. One of the attendees has asked you, well, thank you very much for the presentation, he says, and is this program still ongoing?
So yes, Suelana, as she mentioned, she's now the Health Equity Coordinator, but support to newcomers is part of her portfolio for sure.
So it is, I'm going to say pretty quickly, it is still going on, but since COVID, a lot of our families and a lot of patients, just even in Ottawa, have lost their appointments, have been rescheduled to a later time. So we don't see as much families as we do now. We only see urgent referrals in clinics, but our families will still reach out with their interpreters, but we are still seeing a high number of interpreters being used since the billing forms do come to my office. Families are still reaching out to the emergency department, but we've noticed that our interpreters are still our families are still really scared to come in because they don't frankly really understand COVID as well as anyone who understands it in English and French.
Great, thank you. Another question, can the Newcomer Navigator framework be replicated in other sectors besides healthcare?
One of the interesting things that exist is these, what they call them, Swiss workers. These are, they're not everywhere, but they exist in schools, and they are meant to help. Can you imagine some schools had so many newcomer children arrive? And in Winnipeg, and we heard stories of Yazidi children who've been so traumatized by seeing their fathers killed in front of them, and so the fire alarm goes off, and boom, they're under their desks hiding, thinking that must be a bombing that's about to happen. So quickly it was recognized that we need additional supports in schools, so that's existed. I think there's other sectors this could apply to for sure. It's just taking that equity lens and thinking about what are the barriers to them having an equal experience to the other children or adults. I definitely think it's adaptable.
Great, thank you. Another question. Does IFH cover the medical equipment, such as the ones you mentioned, Suelana, at home right now?
IFH doesn't cover it 100%. So what IFH has provided now is like a booklet of the equipment it provides and its services. There's still medical equipment out there that IFH doesn't cover, just such as cochlear implants, like OHIP would. There's some monitors that IFH doesn't cover. There's some CPAP machines that IFH doesn't cover. So basically whatever is listed on the document, which you can find on the IFH website, will let you know what equipment is covered. And at times we've reached out to IFH and said, listen, like, it's a little bit ridiculous that this is not on your list. This is the reason why, and this is the increased number of patients we've seen who require this equipment. Can we consider adding it? And we've seen times where the equipment has been added to the list.
Great, thank you. And we have one last question. Do you involve some newcomers in some of your CHEO committees, such as the Family Council?
We do, actually. We have we have a newcomer, Hanan, who's sitting on our family advisory committee at CHEO. At the beginning, I'm trying to remember if Hanan, we've had a couple of gone through, but we provide interpretation as needed. It does require a bit of a reach out, a bit of a confidence boosting in them that we think they'd be a great addition. Because at first I'm like, well, how could I possibly contribute? I'm a new Canadian. How can I possibly help a Canadian system? But that's been great success. And I know N4 actually has a family advisor a family advisor and a youth advisor who have lived experience who sit on N4's advisory committee. So definitely. Yeah, it takes extra work though. You've got to go to them, or have somebody like Suelana to identify them to your engagement staff to say this person is really great. They can think outside of their own experience and think broadly, and that's where Hanan and Busi have been great about that.
Great, thank you. I see a few more questions have come in, but we've reached our time. So I do welcome other questions. You can email me directly and I can pass on the information to Christine and Suelana. We'll open up questions for a few days following today's session, and they'll get back to you personally with the responses. In the meantime, thank you again so much, Christine and Suelana, for your very passionate, informative presentation. We really appreciate your time. And thank you to all of you for today joining our inaugural presentation. We do have some upcoming N4 webinars and we hope to see you there. And as a reminder, we are posting today's session online. It will be available on the N4 platform within 48 hours. And again, thank you. And we look forward to seeing you in a future presentation. Stay well and stay safe, everyone. Thank you.
Thank you.